opportunity to co-lead this team, and it was to do with transitioning and mental health. And this is our agenda, so you can see the order that we're speaking in. We're all taking part in doing the report out today. This is our team, and I'd like to introduce some of them. We've got Natalie, and we've got Darlene, we've got Ashley, Alexis, and Claudia, and our little helper today. These guys said that I was the odd man out in the picture. As soon as I looked at it, I thought, well, that's because all the bags under my eyes. And they said, no, it's because you're the one that didn't have your glasses on your face. So they were right, but all I seen was the bags. Anyway, the title of our project is quite a mouthful, but it is Reducing Defects in Communication Mechanisms During Multi-Disciplinary Transitions Between Mental Health Inpatient Unit and the Community Rehab and Residential Services. So I think a couple of key points under the current situation there to note was that there was an inconsistent process for referring to community mental health nursing. The communication was inconsistent between the services at certain transition points, and there was inconsistent information being sent out at discharge. This is our theme, and we tried to roll it all up together, but I'm not sure we made it any simpler. But it's all community mental health nurse clients will have accurate, useful, and timely information sharing to ensure that they have a safe transition in their care. We started out our work looking at a model, which is it's called the Model for Bridging Care, High Quality Transitions. And it's kind of the ideal to look at for transitioning clients from the time that they enter the hospital system till the time that they go home, and it really does clearly speak to discharge planning. And each one of those rungs on that bridge is certain pieces in that process of transitioning care. So this is how we took a look at it. We took and cut up that bridge into pieces, and we started out by looking at 3 different critical incidences that have occurred over the last year. And there was, some pretty significant outcomes that came with those critical incidences. And so we wanted to see, just as a way to try and look at that, was there certain areas, if we looked at that ideal, was there certain areas there that we could pick out that we maybe could work towards improving what was going on for that client? And so this is where we ended up. We ended up starring 3 key pieces in that transition. And one was the discharge planning. The second one was complete communication of information, and the third one was around the availability, timeliness, clarity, and the organization of the information that's going out. This here was the current state, and I know it looks a little bit different than an ordinary value stream map, but I had a really tough time trying to look at what was going on there in a linear manner, because there's so many people or players that are involved with that client from the time that they go into the hospital till they go out. But the key thing looking at it here was that we needed to make sure that that client was the center. But there was key pieces there that were involved, like the interdisciplinary rounds and the nurse and the physician and some of the community pieces out to the side there. But they weren't all really well linked together, and so that's where we took a lot of our focus from. Some of our PQA data that we looked at came from looking at some of the defects, and with the community bridging plan, which is the discharge care plan that's being sent out, they had collected a number of defects in mental health outpatients, and you can see that there's some fairly significant ones out of 21 where the problems were, and the first 2 columns were both about those forms going to the wrong location, and that ended up being 9 out of 21 of them were landing in mental health outpatients in error. That wasn't where they were meant to be. And 6 of them had no community mental health nurse referral, but there was a new injection ordered for the client that was going home. So that meant a delay for that client getting services when they were going home. The other thing that we looked at was the delay in time from the time that the client was discharged to when the community bridging form or plan was received in community. And with those 21 defects that we looked at, there was an average of 5.45 days from the time they had been discharged to when that form actually was seen in mental health outpatients. But we did have some verbal reports that had been longer at times, even up to 30 days sometimes, with different things going on. So we knew that really was where we needed to spend a bit of our time working on. This is a bit of a spaghetti diagram. Again, my mind works a little different than some, but on the right-hand side, you can kind of, that was what I designated the current. So it starts with the bridging care plan right up here, going into the fax machine and then coming out into mental health outpatients. And you can see that the clerk there got tons of them. They were getting many, lots of times every day. The problem was that it wasn't really clear as to who those needed to go to, and she had to spend a fair bit of time sorting. Then you consider the factor that it was a clerk that was kind of sorting, maybe sometimes making clinical decisions, and they had to do some work standard and some work around over there trying to figure out what to do with these. And it even meant involving the manager at times, or mostly every day, to review some of those ones that were really complicated and hard to figure out. So that was, a significant amount of work that was taking place that really shouldn't have been happening. Our target progress sheet, because we really were looking at those defects in communication, that's what we set our defects as being, the number of defects involving the community bridging plan. And so we started with 21, and the goal would definitely be 0 with that.
My name is Natalie. I'm a mental health inpatient nurse. So, in our present state, our interdisciplinary rounds occur Tuesdays, Wednesdays, and Thursdays, and there was 2 problems with that. First being that the unit nurse was not attending these meetings, and the nurse really has the best understanding of what the client's needs are, what their current situation is. And also the community mental health nurse that was attending on Thursdays wasn't getting all the information that they needed. They'd often go back to their office and need to call the nurse back on the unit following rounds. So on the first idea sheet, we thought we would develop key indicators for possible community mental health nurse involvement. And on the second, we decided that we would involve the charge nurse from the unit in the interdisciplinary rounds on Thursdays. So the first change we made was to an existing form. We renamed it. It's now the interdisciplinary phase sheet. And what we added was this bottom section here with discharge considerations. It identifies the need for complex discharge problems solved. Yes. And then we also created on the back side of that form the update for ID rounds sheet. So the nurse on nights is going to fill in this brief summary, reason for admission, and then any pertinent current information on the patient's mental state, and any discharge problems. And then this information is easily presented to the rounds team on Thursday afternoons by the charge nurse. And thirdly, we developed a script for the rounds. And this is created to keep the team on track and provide a script to members that may be filling in for the usual team members that would attend these rounds.
I'm Darlene Zanity, and I'm a community mental health nurse. So our intended improvement was earlier intervention and support from the mental health inpatients when the patient goes home, and support from community resources as an outpatient. What we found with this process is that the community referral needed to be established prior to discharge, so that the community mental health nurse assigned can meet the client, develop a relationship, and establish a plan for when they go home. A few things we put in place to ensure this is going to happen is on the bridging plan, we've made a note well that we need to know if their community treatment order is due or when it is coming due. If they had an injection, we put in a safety net that if the injection is due within 3 days of discharge, that it's to be given in case it's a weekend, so it won't get missed. And the third thing we highlighted was the mental health inpatients will note on the bridging plan that the referral was sent and the date and who sent it.
I'm Ashley and this is Alexis. So prior to the Rpiw, there were concerns around the bridging plans and duplications of faxing or unclear identifiers for the purpose of the bridging plan. A fax cover sheet was created to eliminate confusion on where to send the bridging plan, and it was also identified that bridging plans were not being received in a timely fashion.
So from the information that we gathered on the idea sheets, we decided to create a discharge fax cover sheet that would be attached to the community bridging plan. The cover sheet would be completed by the patient's discharge nurse and includes a section to indicate who the service providers are on discharge, where the information is going, and their fax numbers. So that's the first column to the left and then the column to the middle. As well as a confirmation that the information has been faxed with a checkmark, date, and signature. So the 3 boxes to the right just confirms that the information has been sent where it needs to go. So this form has been designated as a nursing duty and is to be completed and faxed at the time of discharge. The discharge nurse has the ability to designate the faxing of the package, for example, to the ward clerk. But ultimately, the responsibility falls back to the discharge nurse to ensure and verify that it's complete. So what we did was we updated the current work standard to reflect the changes that we made, which included this being a nursing responsibility to ensure that the package is faxed where it needs to go and the timeliness of faxing, which is to be done the same day as the discharge.
I'm Claudia Driscoll. I'm patient family representative. Do staff know who I am and what care I need when I come in and leave the hospital? Communication, regardless of where we are, is key to successful outcome, whatever we do. More so for myself, the patient coming in and out of the mental health hospital. Who will be there when I go home? Paper, I was drowning as patient on the team, drowning with all the paper. All the paper was there to be helpful with my care. But no one was there when I went home. As a team, we learned so much from patient, staff, management, which all help to tune current forms and to add nursing representation to the weekly rounds. The community mental health staff, through the help of Darlene, felt that huge progress has been made to the patient on discharge. I as a patient now have better understanding of my care when I go home, and I won't be alone.
So this is our future state, and you can see it's changed a little bit from the current state in that we really wanted to make sure that the client was encapsulated with that interdisciplinary team. And we made some key improvements in involving that ward nurse and the community mental health team with that client and with the interdisciplinary rounds. And you can see as you look around the outside edge, there's some real key pieces that we touched with this project. Up at the top, you can see that we improved that process for that community mental health nurse information sharing when the client's coming into the hospital. We developed some really key considerations to look at when they're in hospital to determine whether they're going to need some help when they go back out, whether it's community mental health nursing placement, all sorts of things. And then for that nurse to be involved with gathering that information and presenting it around as well. And so then when you look at the interdisciplinary rounds, we've got that script in place for them and also some backup plans there for how that runs if the designated people are not available. The next piece that we looked at is when that community mental health nurse referral is being done. And so we're looking at that being done as far prior to discharge as we can, so that those services are in place for them if that's what that client needs. And then that last piece that we looked at on discharge is around that discharge, the community bridging plan, which is the discharge information and sharing part of it. This is our newspaper, and you can see that we did touch a lot of different things, but we were able to complete a good part of them 100% complete. There was a couple things, and that's the training of the staff that needs to be carried further, but we do have the package ready to go for them. And also there's a binder on both of the units, the youth and the adult side, that it's a fax binder, and and that needs to be looked at and ensure that that's up to date. So in summary, I know I've mentioned some of them, but we developed a standard process for the receipt and use of the client information coming from community mental health. We involved the mental health inpatient nurse and charge nurse to prep and present at interdisciplinary rounds. We improved the chart components to easily enable the pull of the information there for that part of it. We also developed a standard process for running the interdisciplinary rounds and a script to follow. And the discharge facts cover sheet was also developed to simplify that process and make it really clear as to who that fax is intended for, who it's gone to, and then as a way of documenting that then back at mental health inpatients.
RPIW number 61, these are my thank yous. Our co-lead, Roxy Swatsky, she was awesome, and her infamous red pen. My RPIW team, you're a great bunch to work with. Our patient rep, Claudia. Wanda, our quality improvement rep, she kept us on track and kept typing for us, even if it was just one letter. Our process owners, Colleen Toy and Adam Pearson. All the mental health inpatient staff, the mental health outpatient staff, or community mental health nursing department, our mental health outpatient health records staff, and anybody that assisted with data collection and information sharing and preparation of this process. I'm sure it was quite daunting, and you guys reinforced to us that it took a lot of time.